So with that, let me turn to the moderator for the first session, who's Dr. Andy Beinman. He's a member of the Workshop Planning Committee, Executive Vice President and Chief Medical Officer at Kaiser Foundation Health Plan and Hospitals, and Professor of Medicine, Epidemiology, and Biostatistics within the Philip Lee Institute for Health Policy Studies at the University of California in San Francisco. Andy, let me let you take it away.
Well, thank you so much, Mai, and it's a real pleasure to be able to be with you all today. I'm very excited about the agenda we have for you and for this particular session. I have the great pleasure today of opening up a discussion with two outstanding speakers, Dr. Mandy Cohen, who is the Secretary of the North Carolina Department of Health and Human Services, and Dr. Tim Ferriss, who is the National Director of Transformation for the UK National Health Service. You should be able to find more detailed information about their past bios in the materials for this meeting. And I just will tell you, I know they're going to be outstanding people to be able to give us the perspective that we're looking for today. What I'm really hoping to do is to moderate a discussion that will address the vision, opportunities, barriers, and strategy for an integrated health and healthcare delivery and financing system that rewards whole person health and population health and well-being. Specifically, this session will aim to identify possibilities of innovative models and the outlying areas that still need to be addressed. So I'm really excited to just get right into the conversation. And I'd like to welcome Dr. Ferriss and Dr. Cohen to the stage, if you will, with me. And I'm going to throw out the first question. And I'm wondering, maybe I'll ask this of you, Tim, and then we'll turn to Mandy. But what we're going to be speaking about today is the integration of healthcare delivery with healthcare financing. And I'm wondering if you can sort of offer a vision and describe the characteristics of an integrated healthcare delivery and financing system that rewards whole person health and population health. So Tim, any opening comments or thoughts about that?
Andy, thanks so much for the introduction, and Michael and the whole team at NAM putting on this. I really appreciate being asked to engage in this conversation. And of course, any chance I get to see Mandy is a real pleasure. And I actually do need to start off by saying that my comments are a reflection of my my work and in the United States, and a reflection of the U.S. healthcare system. I am brand new to my job as the National Director of Transformation at NHS, and I don't want my comments to in any way reflect on that position or the issues. But I will be speaking generally, and the fact is that the delivery of healthcare, its financing, are all complicated no matter where on earth you do it. But so with that framing, you asked for a vision. I came from Mass General Brigham and Mass General Hospital, I would say a system that is historically steeped in the fee-for-service healthcare system. And we, right at the beginning of the ACOs under Mai's leadership at CMMI and with Mandy, we were one of the first pioneer ACOs, and we went through the process of thinking through what converting a fee-for-service delivery system to I'll use the word capitated. There's lots of different ways, budget-based. Each one of those words has some salience that has some positives and negatives with it. So I don't want to stress about the word, but just say moving to a system, an ACO situation where there are rewards and penalties around costs of care and not just delivery of services. And I just want to say, one of the things, Andy, you asked for was the vision for the future. But at my organization, the need to do that, the requirement that was placed on the entire system of care, outpatient, inpatient, rehab, the whole, all, because basically in mental health, everything was included within our system, was really energizing to the people that work there. Like it is remarkable how much, while challenging and scary because of all the potential downside financial risk we were exposed to suddenly on one day, it was very energizing. And so I want to start by talking about, for the people who deliver care, the transition to integrated financing and delivery can be really energizing and very positive. Having said that, I think we have some, so the vision, we are on the cusp of truly measuring and holding accountable on outcomes, but we are not there. We are not there on measuring, and we can talk about that more in further questions. But it is so close at hand, and yet we are not there. And we should talk about that. The other thing is, I just wanted to put out there that, and Maya and I have talked about this many times. She talked about the fee for service. I don't see fee for service as the enemy, nor do I see capitation as salvation. I just want to say that there are a lot of, healthcare is a very heterogeneous set of services. And you could make I would make the argument that many of those services can and should be paid for on a fee for service basis. In fact, you go around the world, inside delivery systems, I'll bet, Andy, inside your own delivery system, you allocate money sometimes on a service by service basis as a method of allocation. And so I don't want the confusion between the integration of financing to mean that internal to that integration, you're not actually paying for things as you use them. That's just basic economic principle. And then finally, I wanted to just say, this conversation is about the importance of what I would call vertical integration, which is integration around the vertical stack of the delivery of health services, which is financing, and I don't know why, but we put financing above, or the actual care delivery below it. But the goal is actually horizontal integration, as Mai so perfectly illustrated with those 3 case examples. In integration of services for an individual person who needs services is a problem that is horizontal. It's just that we have noticed over the years that the systems through which finances flow, if we can use geometrically that as the vertical, really have a serious impact on the degree to which the players at the coalface delivering care are able to integrate in a horizontal way. So I hope that was responsive to your.
No, that was a great point. And I guess, what I appreciated is you're also talking about the journey, despite the fact that both you and I have taken a journey from fee-for-service environments into fully integrated environments of financing and delivery systems, you at the National Health Service and me at Kaiser Permanente. So maybe that says something also about how transformation happens, at least at the individual level. But let me turn to you, Mandy. What do you think? What when we're talking about integrating healthcare delivery and healthcare financing for whole person and population health, sort of what's the vision you have of that? Sort of what are the kind of the key aspects of that?
Sure. Well, first, I want to thank the National Academy of Medicine for having this really important conversation. Always great to be with you, Andy, and Tim, always wonderful to see you. I think I had the opportunity to train at Mass General and be in that system and learned a ton. But as I think about what is that ideal for me, I think it is broader than the conversation we have just had, and maybe that is my role at the state level here. But I think the North Star continues to be health, right? Health broadly, investing in that health, improving health. But then if you look at that, to Tim's point about that horizontal, what is it that makes up someone's health? Sure, it has a lot to do with what happens within the healthcare system or even the mental health system. But we live and work and play in so many other spaces, and our health is made up from that. So I was struck, so when I think about what does my ideal look like, it's an integration of traditional healthcare, of mental health, of public health, of social services, and of education and other economic forces. So I was really struck by the examples that Mai brought up. Let me do a couple of remarks on those, because I actually think it was a real over medicalization of those examples. Jamal, let's start with him, the 10-year-old boy who had asthma and ADHD. We were left to say, well, oh, the problem is he couldn't find someone to take his insurance. My point is he's in school every day. Why isn't there a therapist that is there integrated into the school, who is there to work with him? Why does mom or dad have to take off from work and or the kids have to miss school or go out, right, to get an appointment? We have missed the boat on how to help Jamal in the setting in which he could be helped. I would say he also has asthma. What's going on at home? Is there mold remediation we need to be thinking about? Or right. So that's just one. And I think about Margarita, and when the answer was like, well, why can't she lose weight? She's pre-diabetic. She's a private duty nurse who doesn't make a living wage. I'll just say in North Carolina, we don't pay our private duty nighttime nurses a living wage here. And yet, our prescription for that was, hey, can you get some more exercise? I want to make sure we take a step back, even in those examples, to say we have to think about an integrated system that looks at health broadly, and so needs to draw, and it doesn't mean that healthcare needs to solve poverty or needs to become social services. It does mean that our system has to come together and integrate, right, and use those financing mechanisms, create an infrastructure to get to those horizontals with that aligned incentives, and then actually think about the process redesign in order for us to execute on that vision of health. So I'm excited about this because I think this is possible. I worry if we go in a place of saying healthcare has to solve it all. It does not. It needs to partner. We need to have some integration, and I think that's the right word, alignment and integration. And I'm excited to get into the details of how to make that possible.
Well, thanks, Mandy. And let me come back to you and then turn to Tim. But, in some ways, I think this discussion got teed up in part because of what we all observed during the COVID emergency, right? Where basically we suddenly had a delivery system that was, for the most part, dependent on a certain way of generating resources, whether that be through elective procedures or other kinds of activities that generated fee-for-service funds that could then be sometimes, redistributed for other kinds of activities. And suddenly we saw that the healthcare system was really struggling because of COVID to be able to be responsive and to be able to have the flexibility needed related to the financing. So I guess my question is, how do you think our healthcare system's response to COVID, might have been different had we had a healthcare financing and delivery system that was really focused on this whole person population health? Would the response have been better overall? Would it have been more equitable? I think we're seeing that our response, didn't necessarily meet what we ideally would have liked. So I'm wondering if you could maybe help us see it through that lens about how financing and delivery system integration might lend more flexibility or other kinds of opportunities to respond. So Mandy, thoughts about that?
Sure. Well, I've had the honor / burden of running the COVID response for North Carolina for the last year plus. And, what I would say is that we really did try to create that integration, but it had happened at the moment of crisis as opposed to the preparation that could have gotten us there. And now I think some of the things were right. And what I really was impressed by was how quickly we were able to mobilize our healthcare systems and integrate that with our public health systems and integrate. So it was possible. And I think that's why this is the right moment to have this conversation, because I think we were able to see when we have a singular focus together with a singular aim, we're going to defeat COVID together. We were able to bring data systems together that frankly everyone fought us on before bringing together, right? Before COVID, I didn't know the race and ethnicity of the admissions to the hospitals across the state. From, if we want to talk about equity, we didn't know who was getting tested for what and where, and how to look at that from a resource perspective. And so I think we have made a ton of progress to recognize that it wasn't just about an access to a COVID test. We needed somewhere safe for someone to isolate and quarantine, then get into housing and food and the other pieces. So I think we've made a ton of progress. We probably put that progress together with duct tape and kind of in spite of the system and some of the financing. And we did it with a lot of luckily federal help and dollars and flexibilities that we put in place sort of overnight. But this is our opportunity to say, what did we learn? What went right there? And then how do we turn some of that duct tape into a real structure that we can go forward with? But I absolutely think that if we had been more integrated beforehand, we certainly could have picked up on things earlier, been able to really focus on keeping the viral spread low in a different way, because we saw if we were able to wrap around communities, we were able to lower viral spread rates. And actually, we're gonna publish some results on that in North Carolina, where we had sadly our own control experiment, where some communities were able to do that really great integration and some places not. And things went a lot better for those communities where we were. So I'm excited about what we've learned over this year, but now we have to really make that permanent.
Yeah, Tim, I turn to you with the same question, and I'm struck by, Mandy, you did reference the federal financing that sort of had to come along and, for lack of a better term here, bail out the healthcare delivery system. And I'm wondering, was that a sign that maybe our financing didn't give us the kind of resilience that we would need to be able to address things? So I don't know, Tim, what do you think? Do you think COVID response would have been different had we had an integrated financing and delivery system?
It's always hard to answer the what if question. Can I try to work my way around it a little bit by commenting on something that occurred that was really terrific, that our approach to financing, and particularly antitrust, is showed how it's working against us. And that is basically all the delivery organizations in Massachusetts, under the governor's leadership on nearly daily phone calls, started collaborating in ways that were absolutely extraordinary. And, a lot of it made the news, like sharing ventilators and stuff like that. And level loading of ICU patients, like extraordinary stuff that had never occurred before. But an enormous amount of stuff, that was just the tip of the iceberg that the press got a hold of. At every level of our organizations, I was having phone calls with my colleagues at competing organizations 2 or 3 times a week, problem solving, like how do you get ICU tubing to get outside the room so the nurse isn't using too much PPE going in and out every 5 minutes, like real-time problem solving in a collaborative way against a shared mission of saving as many lives in our state as we possibly could. And that was occurring all over the country. And if you take a step back from that and you say, wow, we got a lot accomplished through phone calls that are outside of an emergency status, because of the way we've chosen, financing, border on illegal, right? And so that opportunity really shone a light on what is possible if we are actually collaborating and cooperating toward health. And that's just an extraordinary, it seems like it highlights an extraordinary opportunity. The other thing I will just say about integration, and this is very narrow, I really commend Mandy for widening the focus. I'm going to go back, sorry, Mandy, to the more narrow focus just on this point. And that the point is, when you're part of a large organization and a major crisis hits, the resources you have available to redeploy are extraordinary. So we were able to move things between hospitals, under the same budget, it's on one organization. We were able to move staff between organizations to address needs, to make sure that we were in real time making decisions that enabled us to stay ahead, like a couple days ahead of the care delivery crisis that so many places face. That, in that particular case, the integration of financing and care delivery across a large accountable care organization was really advantageous.
So what I'm hearing from both of you is that, that during COVID, you're still found flexibilities under the current payment mechanism, and perhaps, not to get you arrested, Tim, you said maybe you were skirting some of the laws to be able to do that, but it does sound like the emergency set up some ability to have that flexibility that maybe was needed to be able to respond. But I wonder, if looking back at it still, whether there are ways that you would reflect and say, hey, could we move closer to a vision of success that would be more sustainable, that would have more resilience and doesn't require enormous ingenuity? And maybe it always requires that at the time of an emergency, but that flexibility is accounted for in some ways. So I'm just wondering, maybe I'll turn back to you, Tim, first, is sort of, do you see major opportunities either coming out of COVID or in other ways that you have seen your own organization at Mass General transform, or what you've begun to see early on at the National Health Service, where there could be success to sort of have that flexibility to be more focused on whole person care, because the financing is just more available to be bent in that direction to meet that? Or is that not the fundamental place that we need to look? It seems like it could be quite important. That's sort of a premise, I think, of this meeting. And so, your thoughts on where you see, major opportunities to maybe work toward that success. So Tim, what are your thoughts?
Well, I'm going to pick up on you. I could go a million different ways with that question, but let me try to say it goes without saying, but let me just say it. It is so much easier to get everyone to row together in a crisis where what you need to do is very, very clear. The delivery of healthcare, and again, I'm embarrassed I'm being so provincial, Mandy, but I'll let you expand it. What you need to do in healthcare is you've got to treat cancer and cardiovascular disease and trauma, and there's so many disparate things that it's much more difficult to find common purpose around, and I'll use this word, outcomes, when the outcomes are so varied. Human biology is so variable, and the pathologies that afflict it are so variable that it's really hard to go from that singular purpose in crisis and then translate that to say, well, the whole system, you know, if we could just act that way for the whole system, but then you think, well, the whole system has to deliver such incredible diversity of services. And that's why I want to come back to this word outcomes, because in fact, we have the means, both the technical means and much of the infrastructure necessary to deliver accountability based on outcomes. And we just we're not doing it. And there are so many reasons why we're not doing it. But I would say one of the chief reasons is we do not have a national plan for delivering based on outcomes. If you take all the society-specific registries in the United States, risk-adjusted, endorsed by each specialty society that deliver outcomes scaled, just what NSQIP does, or any of the National Surgical Quality Improvement, the cardiac surgeons registries, those exist now for every specialty. Huge numbers of our doctors in large centers are participating in them already. And yet we have every single, I'll throw Mandy under the bus here a little bit, state has different Medicaid requirements for what they measure. Every single insurer has different requirements for what they measure. Medicare has different requirements for what they measure. If we all just chose to measure risk-adjusted outcomes on this, like, you'd get, of course, there's a huge diversity, but you could pick the 20% of things that are responsible for 80% of care, and they already exist, they're already in use, but they're not used for accountability. They're not even publicly reported generally, except for the cardiac surgeons. And what I would do to move us in that direction, Andy, is get rid of this would have to be regulatory, but I would get rid of all other quality measurement, because it's mostly noise. I'll just say it's mostly noise. And really hone in on the truly things that matter, like at Michael Porter's framework for how we think about outcomes. I love that framework. It's exactly right. It's mortality, it's morbidity, and then it's patient-reported outcomes. You know, and if we got together around that as a country, it would help us integrate financing, because we would have the same, we would be orienting the financing around the same set of outcomes, independent of where the source of funding is. Sorry to go on.
No, that's great. And Mandy, what do you think about that? I mean, do you think the changing of the financing would allow us to focus in a better way on, you know, outcomes and quality that really matters for the health of individuals in our population?
Yeah, I want to pick up. I think where Tim is heading is exactly right, but I want to layer a couple additional things, because I do think that singular focus, Tim, that you're talking about is so important. That aim, again, for me, the North Star continues to go back to health, and that is very broad. But okay, let's go with that construct. You need clear measures of health, and I agree with you. I like that Michael's framework of morbidity, mortality, and what is patient's experience? What is their measure of health for their own self, right? It may not be 10 pounds less, it may be playing with their grandkids, right? So how do you measure that in a way that's meaningful? So I do think you need to have some clear measures of health. I think you do need the payment alignment, right? So you need the payment incentive alignment. Right now, it's almost hard to do the right thing, right? What we don't want is to have our payment structure incentivizing the wrong thing to do, right? So incentive alignment with those clear measures, with a focus. But let me add two more pieces to that. I think there is shared infrastructure that is needed to make that possible. And then I think there is process redesign of the actual delivery. And this is where Tim is, you know, expert on that. But I think you can get the payment, you know, work on the payments and get it risk adjusted and try to pay for the right things, which I don't think we're doing now. I think we can say, I want to buy this. This is the outcome I want. if we could all agree on that. But then you're still going to need some shared infrastructure. Sometimes that's data exchange and interoperability. And frankly, some of it's relationship and conversations, like let's not forget those. And then it's actually, what do you use your time? Like if I'm waking up as a primary care doctor, what does my day look like and how is it different than in our current world? How, if I'm a care manager, what does my day look like that it didn't look like two weeks ago? So I think you need all of those pieces, but I think those feel right to me. And when I did see glimpses of that in our COVID recovery. To go back to Tim's point, we really did. I was very excited about it. I said duct tape happened with infrastructure and the process redesign. We at the government level, we said forget about those quality things, focus on these things. It was great. We invested in infrastructure and sped up our data exchange, right? So we had a moment. So I think we show ourselves that it's possible, but you needed to have that like laser focus. You needed to be all rowing in the same direction. Then I'd go with that payment and incentive alignment, the clear outcomes, some infrastructure, and then the process redesign.
Well, that's super. I guess, in both of your cases, I guess I would ask, and I think you're providing kind of a way to get a direction and several things that need to be in place. Both of you have been involved in trying to bring about some of that transformation. Is it possible to sort of order them and put them into a prior, like first let's fix the data, or first let's do this, or is it kind of, we got to do all those things together? Maybe some general thoughts about how do we kind of not make it seem like it's a daunting change to kind of transform the whole system overnight? And so any thoughts about prioritizing? Mandy, I mean, what do you think?
Yeah, well, I'm a very tactical person, and I talk to my team about prioritization at every moment. And I would say a lot of this work we started in North Carolina before COVID. So I think it is possible. You don't need a crisis necessarily. I think you do need that shared aim, and that keeps you focused. For us, we started in two ways, but there is no one solution, right? It can't be, I'm just going to tweak my payment levers and hope all the downstream things will happen. It's not, oh, I'm just going to create infrastructure and hope magically everything is going to revolve around it. We had to change a bit of all of them, and it takes many, many years to line that up. We did start with an infrastructure investment to show folks we were serious about it here in North Carolina. So we said, look, we know if we are going to think broadly about health, we're going to need a platform that can allow for frankly, the healthcare system and the human services system and the public health system to all talk to each other, share that data, and frankly, help us make resource investments in a smart and strategic way as a state. We're going to have one platform for the state of North Carolina. We're not going to have one at UNC and one at Duke and blah, blah, blah. We're going to have one, and we're going to invest in it in a private-public partnership. So that was our starting point to say, like, this is real. We are going to invest our dollars, and we're going to do it in a shared way. Then we said, okay, the money has to work as well. We have to pay for things differently if we want things different. This is where I asked the federal government for permission for our Medicaid program to use our dollars differently, to pay for things that would drive towards health. And then we're going to, not just a small pilot, but $650 million worth of spend in our Medicaid program, which is still too small, I think, to really think about this alignment, but at least, again, a start. And at the same time, we really invested in primary care to say, here, we're going to pay you differently to screen, to refer, but also to be an advanced medical home, to think about your process. What I would say is the care delivery process redesign is still, I think, the piece of the puzzle we really have a lot of work to do on. I think I'm excited about what acceleration we were able to do in telehealth and virtual health as we go forward. I'm hoping that unlocks some new opportunities here as well. But I would say we're getting better on incentive alignment. We're getting better on some infrastructure. I do not feel like we are there on measures. I totally agree with Tim. We have a lot of work to do there, and we have a lot of work to do on the process redesign.
Great. Well, Tim, anything you would add? I mean, I heard Mandy say she got some financial flexibility through the Medicaid waiver. She's built data infrastructure and invested in primary care. Would you make similar choices, different choices? What do you think?
Well, I would never second guess Mandy's choices. Two things come to mind on both ends of Mandy's really excellent thinking through that. One is a communication strategy issue. And it's always important to, because a lot of people are going to lose things. And we just got to identify who's going to lose and what are we getting as a communication strategy. So, at the low end, the frictional costs between insurance and providers has been estimated at 50 billion a year. At the high end, it's 500 billion a year. It's probably somewhere in the 100 to 200 billion dollars a year that goes into the frictional costs of the lack of integration of financing. And right, so just that alone is a stunning number, right? A stunning number. And so you think, wow, what could we do to provide health, social care? Like, we could fix Betsy Bradley's chart of the US. Do you like that, Mandy? Just taking the frictional costs of the transaction costs between providers and payers out, or just reducing it by 80 or 90% and making it much more like what every other country in the world's transactional costs are. So our transactional costs are just extraordinary. And if we could pull those out and spend them on caring for people and improving their health, wow, that's extraordinary. So I like having the idea of something that we're moving toward. And then I'll go to the opposite and talk about, Mandy said the processes. So one of the things that I will say got me really excited about working in the NHS is end-to-end redesign. Like, there are no losers in the system if the whole system is owned, right? So it's extraordinary to think about this, but we are redesigning ophthalmology care, incorporating new technology and retinal scanning, and we get to rewrite job descriptions. We get, like, everything can be different because the incorporation of digital and all the opportunities, and that kind of process redesign at the coalface is really, really difficult if everyone sits in their own financial silo, right? How does that work if they sit in their So at the point of delivery of care, if you don't have integration, what is the chance you're going to be able to create end-to-end processes that are modernized and fully optimized for everything we know now in science and digital?
Well, that's really right on, both of you, and seems great in terms of the value that we are anticipating that comes from this kind of integration. I guess I'm wondering, is there untoward effects, though? Like in everything where you sort of think about change, you're kind of imagining all the wonderful things that come. Any thoughts about, gee, what'll be harder, or what's the downside risk? I'll use an analogy I have in my own head and see if it matches at all what you might comment. But to me, moving toward integration of payment and delivery system is a little bit like participatory research, where it makes tremendous sense to sort of get the end users kind of connected up with, the researcher and kind of have that alignment. But it's also a slightly more cumbersome process too, right? Because you're negotiating with more people. It's unlike doing research in a vacuum and then saying, here are my results, now use them. And I'm wondering, do you think that's an element of, if you're integrating the financing with the delivery system, that is there a lot more work up front, but then once you get it, boy, is it magical? Or anyway, the thoughts on that, Tim, or I'll start with you and then we'll close with Mandy.
Yeah. Well, I'll just agree with you. So yes, there's a lot more work up front, and I'll tell you, getting the stakeholders together and getting them to agree, but it's like painting a room. right? So it takes so long to prep the room. But once you start painting, actually the painting process itself goes really quickly, but it takes a huge amount of time to prep the room. You know, I'm a big fan of Michael Crichton's first book. The only book that wasn't a bestseller that he wrote was called Five Patients, and he wrote it as his senior thesis at Harvard Medical School. And he wrote it about five patients that he met on the floors at Mass General. And the frontispiece of his book has two quotes, and the two quotes I think capture that dilemma that you're just describing, Andy, which is, he said, only doctors and nurses can change healthcare. That was quote number one. Quote number two was, and I'm paraphrasing a little bit, healthcare is far too important to be left to doctors and nurses. And so the fact is that to change healthcare, it is literally the work of the people delivering healthcare that needs to change. They have to be involved in that change, but they have to recognize they are not the only stakeholders. We are all stakeholders. And I think that's what Michael Crichton was, by putting these two quotes together, he was articulating the tension that you are describing, Andy, about the accountability of medical care, but the fact that it is somebody's actual day-to-day work, and they need to be part of that journey too.
Great. Well, Mandy, let me turn to you for the last comment. Any thoughts about this, things that we should have our eyes open to as we think about maybe the benefits, but things to watch out for, to add to what Tim said?
Sure. I think I'll add one additional word, is the culture of healthcare and the culture of medicine is strong and intense in a way that change is incredibly hard in any industry and in anything. I think very much so in healthcare. And so thinking about, not, again, incentives and payment structures and getting to measuring what matters, and getting that infrastructure right for the interoperability. I think we have to pay attention to the culture piece. And I think this is what Tim was very much getting to. I do worry, as we think about health broadly, that there could be a tendency to over medicalize every piece of health, where I don't think it needs to, right? Where I was saying that the second patient, I think Marguerite, her health issue, my brain went straight to living wage, just like the world I live in now. But I hope so. I hope that becomes a broader way we think about this, and we don't medicalize everything. We actually look at someone's totality of who they are and their circumstance, and where are the intervenable places. And that's not always with a diabetes med. Sometimes it's something different. So, and I'd also want to make sure that we are listening to the trusted community partners. And again, this is where healthcare doesn't have to solve all the problems. I do think it's probably going to have to quarterback or be the orchestra conductor, but I don't want them to railroad everyone over and be like, cool, I'm now the expert in housing, and you're like, you're not actually the expert in housing. And so how do we facilitate those partners? But being a good partner on both sides, it takes resources on both sides to partner. And so I think we just need to be thoughtful about that as we think about integration, to make sure things are resourced. And I do think we're going to have hard conversations, and the ability to say, like, not everyone is going to be a winner at all times in all moments in order for us to achieve these aims. And how do we work through that change management? I love the image of like changing a job description, literally, in the middle of someone's career. Like, that may happen to a doctor who is trained in, and we need to be open to that. But I think there's a lot of cultural pieces that we need to keep at the forefront as well. Really important leadership moment.
Well, thank you. Speaking of leadership, let me just extend my great thanks to two extraordinary leaders, Mandy and Tim. Thank you for such a terrific conversation and for kicking off this meeting in such a thoughtful way. I'm going to turn it back over to Mai now. So thank you very much.